Hello, everyone. Welcome to my channel. Today, we're going to be talking about diabetes and the management of diabetes. And if you have not subscribed, this is time for you to hit the red button, subscribe, and share this video. Okay? So also hit the notification button so next time when I upload, you can always see it. All right, so let's go into the today's topic, which is diabetes mellitus management. What is diabetes? And what is the causes of this diabetes? Or who suffers from diabetes? Diabetes is caused by two different ways, or can happen to us in two different ways. We have type 1 diabetes and we have type 2 diabetes. Type 1 diabetes is usually when there is an insufficient production of insulin in the body. When the body cell respond to insulin, it's not, sorry, let me take it again. When the production of insulin is inadequate for the body, that is when type 1 diabetes happen. It's usually involve an autoimmune dysfunction. Type 1 diabetes also involve the destruction of the beta cells, which produce in the isolingerham of the pancreas. It can be triggered by certain generic tissue or virus infection. So diabetes can be type 1 and it can also be type 2. When it's type 1, it is caused by, trying to see, this light is kind of little dark. So when it's type 1, it is caused by autoimmune immune dysfunction and by the destruction of our beta cells in the pancreas. But when it's type 2 is the inability of the body cell to respond to the insulin that is present. So the body's inability to respond to the insulin that is present. So when we have type 2 is not a progressive condition. It's not condition that just come in. Some people live with type 2 for several years without knowing that they have it. So type 2 is progressive. In type 2, the insulin production is decreased. And there is the increase in the inability of the body of the cells to respond to insulin. This type 2 is commonly linked to people who are obese, the people's lifestyle, usually people that, do not exercise much, do jobs that, you want them to sit in a particular place. And that's why we encourage movement and exercise. It can also be hereditary. So type 2 diabetes, let's recap. In type 2 diabetes, this person is producing insulin, but it's not producing enough. But in type 1 diabetes, there is also inadequate production of insulin. There is an increase in the body cell, inability of the cell to respond to the insulin that the body has in type 2. So in type 2, the person is producing insulin, but the body cell it's not responding to the insulin. Does that make sense? At this point, if you have any question, just write it down. But if you want to chip in something, you can just go ahead and do so. I will take a question. But if there is no question, we can also progress. So, on which type of people will you see diabetes common? It is common in African Americans, which is the African, when I say African American, I mean the African descendants, whether it's African in Kenya, we're all African. So in African American, because sometimes people say, okay, it's a common in African American, it's not common in Kenya or Nigeria. No, we're all African descendants. So it's common in Africans, it's common in Native Americans, and then in Hispanics. In Hispanics. And this disease is commonly found in male. It doesn't mean it's not found in female, but it is commonly found in male. And when I say it's common in these people, doesn't mean that other race doesn't suffer from, but where we have the greater number of people that suffer from this disease. That's what we mean when we say that it's common in these people. So the most important thing, there are two certain things that I want you to know in this. That when people are diabetic, they are polyuria. That means you see them urinating so much in this. But today I won't go in much to the signs and symptoms that you will have to see. I want to dive in right away to the patient education. I think on the next video I'm going to deal with the signs and symptoms. So on this patient that is diabetic, we have to advise them or teach them to regularly exercise. We also have to have them to monitor their intake. They have to have a consistent food intake, promote glucose control. They also have to monitor their glucose, which is they have to check their blood sugar before and after meal. In some cases, they have where they do like the calorie count. If their blood sugar is this, they do like calorie count on how much calories they take. But in some facility or most facilities, we use the sliding scale. The doctor usually order what is called a sliding scale. In this sliding scale, we have, if the blood sugar is this XYZ, then give 2 units of insulin. If it is this and this, give this unit of insulin. So depending on the facility, depending on what the doctor ordered, because every facility is different. We have the low sliding scale, we have the mid, we will have the high sliding scale. So depending on what the doctor ordered. So you teach the patient to be able to check their blood sugar. We teach the patient to use the sliding scale. We also teach the patient on how to inject the blood sugar. So we also teach the patient to consume diets that are low in saturated fat and decrease the diets that has low density lipoprotein, the LDL food. So how do we diagnose diabetes? The first way, the best way, or the way we do that is through the A1C blood check. This is done in the lab. The blood is drawn and taken to the lab. And if the A1C is greater than 6, it's considered that the patient is diabetic. When I say 6, it depending on the facility, but some people say it is 5 to 6. Some people say 6. So depending on the facility that you work with, check with your facility protocol with what they uses. But when it is greater than 6, it's considered if the patient is diabetic. And usually when patients are diabetic, usually if it's type 2, this type 2 can be treated with oral anti-diabetic medications. But with type 1, they usually require insulin. And having said that, in some cases, when type 2 comes into the hospital for surgery or for some kind of illness, the doctor usually like start them on insulin. Why? Because when the body is stressed, when during their sickness, um, during the surgery or during the whatever that brought them to the hospital, the body is very stressed. So the body tends to produce more insulin. And in order to help control that, they give them insulin, which usually works faster. We have different kinds of insulin. We have the long acting and the short acting. So, and the intermittent acting. The regular insulin is usually like the Novolog insulin, which acts fast, which usually takes like 30 minutes. Before you give a patient this insulin, you make sure that their meal time is close, because you don't want to give this insulin to the patient and wait for so long before they eat. Otherwise, their blood sugar is going to drop so low. So we have the long-acting one, which is the Lantus. And Lantus, one thing I want to tell you about Lantus is that Lantus can never be mixed with any insulin. So Lantus is a long-acting. It works over 24 hours. It can be taken for a whole day. Usually some people take it at night and then they take it the following night. Some people take it in the morning and then they take it the following morning. So depending on how you've been used to having it, I've had patients that are in it in the morning, and I've had people that are in it in the night, depending on what you find comfortable or what your doctor advised you to. In the hospital where I was working, we usually give it in the morning, or the doctors that I've worked with there like to give it in the morning. And I think I also like it in the morning, because if something is happening, if there is any signs and symptom of hypoglycemic, you will be able to catch it. Somebody can catch it right away. Sometimes in the nighttime when they are sleeping or things are slow, some patient doesn't even want you to go to their room, and so there is less movement. So sometimes it takes a while for one to catch it. It might catch it in the morning. I remember working in a nursing home in the morning, a patient that nothing was happening to in the morning went down to like 40 in the blood sugar level when it was checked. And then we started giving, and this lady gets Lantus in the night, every night. So I don't know, maybe she didn't eat very well, or I don't know what happened. But in the morning she was so lethargic, so confused. So when the CNA went to check her, she was confused and everything. So I came to check the blood sugar. I used the first stuff and check it. It was 40. I went and grabbed the other one, and I felt probably this one is not working very well. So when I checked it at that point in time, it was 30. And I was like, oh my God, passing out. And she couldn't drink or anything. So I grabbed glucagon and gave it to, and then, get the blood sugar up. So we're going to come back to that, and I'll also let you know what is glucagon. But let's go back to Lantus insulin. So Lantus insulin, like I said, it's a long-acting insulin, and it is given once a day. And it can never be mixed with any other kind of insulin. So we also have another one that is called NPH. NPH is an intermittent insulin. It's not fast, it's not long lasting, it's not regular, but it's in between these two. And it takes I think it takes like 2 to 4 hours for it to it, be effective. I will let me look into it and also let you guys know what that how that works, because that might be on the test also. Um, so the intermittent insulin, the NPH. The NPH control the meals and its delayed insulin absorption and extended duration of this. So the insulin administer NPH insulin subcutaneous, and the insulin is mixed with short-acting insulin. So the only insulin that you can mix is the NPH. So, and if you're mixing insulin, the first one you're going to draw is going to be the regular before the NPH. The NPH is usually look clouded and mixed with something. So, and that is usually the last one you draw. Your textbook do not have how long the insulin, the NPH lasts, but I think it's between 2 to 4 hours. When we come back to the class next time, I will get that information for you guys and make sure that everybody kind of have it. So, but for now, so let's continue. So we have the long-acting insulin, and we have the short-acting insulin, and we have the intermittent insulin. So, which I said the short-acting is Novolog, the intermittent is NPH, and the long-acting is the Lantus. So I also said you have to educate the patient to check their A1C. Usually some doctor put them to be checked like 3 times in a month. So they go to their doctor's visit and this is checked. So that is one of the things that I want you to know. So going back to diabetes. So when patient is hyperglycemic. So what do we mean by that word? We mean that the blood sugar level are usually greater than 250. So, and some of the things we're going to see on this patient is excessive urination, which is called polyuria. So this person will be so always frequenting the bathroom. Then another thing we can see in this patient is excessive polydysplasia, which is excessive thirsty due to hydration. The loss of skin tone, the skin is warm and dry, the mucous dry membrane, there's a dry mucous membrane, there is weakness and malacia, and then there is a rapid, weak pulse and hypotension. So there is hypotension. The blood pressure is usually very low. So, and there is also polyphagia, which is excessive hunger. This person is eating, but it's not, continue to eat, continue to complain of hunger, even though he has just finished eating. So the reason why it happened is because the cell of the body is finding it difficult to receive the glucose, because the insulin or the cellular resistance that is available in the body. So the body is not absorbing the insulin, it's not breaking down and absorbing this food and sending this nutrient, this glucose to the brain and to every part of the body that is needed. So the body is still feeling that it's hungry. The brain is still sending that signal to the body and saying, I'm hungry, feed me. I'm hungry, feed me. So that is what usually happens. So another thing that I also want to let you know is that before a patient is going to be doing this blood glucose, the A1C, we also want this to be done fasting. It's not something that patient has to eat before they go. It has to be done fasting without food. So the other sign and type of hypoglycemia, another finding or something we expect in diabetes is hypoglycemic. Hypo. The first one I talked about was hyper. So when this patient has what we call hypoglycemia, so in hypoglycemia, this patient has low blood sugar, usually anything less than 70. It's considered hypoglycemic. So in this patient, when patient is hypoglycemic, you see them they are weak, they are tired, they are sweaty, um, they are sometimes if you get to a certain point, they become unconscious, you become unconscious, dehydrated. So it's especially if you see a diabetic patient getting unconscious and getting lethargic or weak and sweaty, please check their blood sugar. It doesn't hurt. You don't need a doctor's order to check blood sugar. So just check the patient's blood sugar. You might be surprised to find out that this patient's blood sugar is very low. So, and that will help save somebody's life. So, we also advise people taking insulin or people who are diabetic to eat regular diet at regular interval, avoid alcohol, and then to wear medical bracelets. So one other thing we do is if he's wearing a medical bracelet, it helps it help them because sometimes when they are going to ketoacidosis, they smell like they've been drinking. They have this confusion going on. This might start happening in a car. I've heard of the story where people were stopped in the car and not knowing that this patient was sick and the blood glucose was very low and everything. So the police thought he was drunk. Instead of getting him the help, they just arrested him and wasted a lot of time. By the time they looked at it, it was like the patient was almost like gone. So, but I think now the police are trained to know to check blood sugar, or to send people like that to the hospital to be checked out. They are trained to know that some people have some medical issues. So, and wearing this medical bracelet saying that you're diabetic or something, it also helps because when police arrest you or when you collapse on the road, a good Samaritan or somebody found you on the road, you will be able to find help for you, not thinking that you're just a homeless person on the road or that is just passed out, or somebody, one of the drunkards or drug addicts that, just find his way on the curvy. So you will be able to find help. So that medical bracelet helps. So another education we need for patients that are diabetic is making sure you ask them to check their legs all the time. Especially they can use mirrors to look at their feet, because what happens is that after a while they lose sensation on their feet. And when they lose this sensation, they can step on nails, they can step on hot plates, they can burn themselves without knowing that they are burnt. We have had several issues about this, and then people coming. There was one guy that was living by himself. He's about 70 years old, doing fine, but he's diabetic. It was during the Thanksgiving, family came with turkey and food and everything. So they all came to eat. And the son looked at him and looked at his leg and saw this big sore on his foot. But daddy did not see the foot sore. Daddy did not know there is anything there. He's not feeling any pain. So thank God for family that visits. their loved ones. So that was how the Thanksgiving dinner turned into a trip to the hospital. He came to the hospital and he was admitted, and they did everything to save the leg. I think the leg was saved, but some of the toes were cut off because it was beginning to eat up. I don't know what he stepped it on, and he kept saying he can't feel anything. So some of them can't feel anything. So teach your patient to always check their feet on daily basis. They can get a mirror and put it underneath their feet and look at their feet. That will help them see whatever is going on down there. If they are not unable to see, we as caregivers or family members should able to inspect their feet to make sure they have not stepped on something, because sometimes some of them cannot feel. Diabetic wound is one thing that it is so hard to heal. I can say, it is so hard to heal diabetic wound. I love wound. I love wound care, but diabetic wound, it is so hard to heal. Because my joy about wound is just that when it start healing and healing, you see when it started and then you see when it stops. So the one for diabetic wound is kind of hard. Every time it's hard. What happened? Because the insulin, it's not breaking through. It's not sending all those glucose, all those nutrients into where they are supposed to be. Because what do we need for these wounds to heal? We need protein. We need vitamins. We need all those electrolytes for us to heal, for the wound to heal. So if we're not getting it, it's going to be a wasted effort. So I am going to stop right here, and next time we will continue from here. Thank you, and make sure you subscribe and share. Bye.